So herniated disc, we've all heard of herniated disc. What does it mean? Sometimes people think that it's a herniated disc that automatically needs surgery. Well, the fact of the matter is that the natural history of herniated discs are very good. About 90% of them just resolve on their own. They may shrivel up some, they may get smaller. The impact on the nerve may resolve. That nerve initially, when it gets this big disc pushing on it, feels terrible, and there's a lot of nerve pain, and it's very bad pain. But the nerve swelling can go down, just like if you look at a sprained ankle. You'd say, how is that going to get better? But the natural history is that many times the swelling does go down and it gets better. So in my experience, I would say the same, is that 90% of people, even when they come from the very beginning with severe pain, oftentimes with some time and medications and some period of rest, they oftentimes will get better. Another option with herniated discs are epidural steroid injections. We've all probably familiar with that. It's the same type of injection that women have delivering babies. It's in the same place in the epidural space. And it puts a strong anti-inflammatory, which is a cortisone steroid, right where this inflammation is. And cortisone and steroid are natural. We have steroids in our bloodstream all the time, so it's not like putting some terrible chemical in a place like that. It's taking a natural substance that's an anti-inflammatory and putting it right where the inflammation is. Now, 10% of the time, it continues. It's maybe a big disc herniation, the nerve is not responding, the swelling's not going down, and there's a role for a microdiscectomy, which is to take that small fragment of the disc out. And it's something that has improved to the point where we typically will do this as a day procedure. Someone will come in the same day. They'll go to the operating room and have an anesthesia, an incision in the back, probably about that big, and we come down to the muscle and just retract the muscle to one side so that we can see this area where the disc herniation is at, and just take that fragment of disc out. So most of the disc stays there, but just the fragment is removed. It's a procedure that has 90% great results, so I don't hesitate in thinking that if somebody has been having pain for over 6 weeks, it's bad pain, it's not responding to things, and it's a clear sciatica, all the history and physical exam correlates with the MRI scan, I think it can be a very good option for someone. It's never a necessity, because eventually even that person would get better. There's a study that shows surgery and not surgery, if you get out to 5 years, they're the same. So it's, even with that, it's not a necessity, but on times I think it can be a very good option. So then the spinal stenosis. This is really related to the arthritis, and this is the same nerve canal that we saw before where the spinal cord is traveling. Now this is a myelogram because I can see this white dye around here, and then these little small dots are the actual nerves there. Again, back here is the facet joint on either side, and it's a little bigger than it was when this person was 20. It's gotten a little bulkier. We see arthritis when you see the finger joints. They get a little bit bumpy and bigger. When that happens in the spine, it starts taking up room that the spinal cord would like to have. And maybe the disc bulges a little bit. And it all combines to take that neural canal and narrow it. It's almost like somebody's got their fist around it, just kind of squeezing, so there's not as much room. So we talked before about the grocery cart sign, the bent forward posture, leg pain with standing and walking. Here's a picture of a spinal stenosis, which is very severe. So this is very, very narrow. Usually it correlates fairly well with symptoms, but not necessarily. There are some people who have a narrow canal, their nerves are resilient, and maybe their activity level is not really active, and they say, I'm doing okay. There are other people that a canal like this, it would be just too hard to tolerate. The pain and inactivity would be severe. So, here's a picture, wider canal, narrower canal. We talked about about treatment for herniated discs. Treatment for spinal stenosis, oftentimes very similar. sometimes non-steroidal anti-inflammatories, the Advils, Aleve, and there's a maze of all these anti-inflammatories, and it all started out with the grandfather of the anti-inflammatories, which is aspirin, and aspirin is still as good as any of them. Now, spinal stenosis, if people have this, the issues with it are that we have these options. We have, again, the option of the epidural steroid injection to put anti-inflammatory medication right where this inflammation is. We also know that it doesn't change fast. So if somebody had spinal stenosis and they were nervous about it, they didn't want this to progress and they didn't want to be in a wheelchair in 3 months or anything like that. Well, the statistics are comforting, knowing that it changes statistically very, very slowly. So if someone's doing okay with it, there's no rush to say we've got to do something active with it. If they're not bothered an awful lot by it, their activity level is reasonable, no rush to do anything really active. When it does bother someone quite a bit, there is the option of opening up of the canal where the nerves are. And it's something that oftentimes it would be a little bit bigger incision than the disc. It would be probably an overnight stay in the hospital and go home the next day, usually. The statistics, again, are very good. They're probably 80% good and excellent results. So pretty good statistics, particularly if everything makes sense. If the symptoms that someone has are classic standing and walking leg pain, the MRI scan or CT myelogram is clear that it's pinching right at that spot, then opening up that area can be very gratifying. So some of these couple of surgeries that I would do are honestly some of the most gratifying that I would perform, because it really can take pressure off of a nerve and give improvement to somebody. Sometimes back surgery gets a bad name. Someone says, the last thing I ever want to do is have a back surgery. Well, I would say that it's the same thing, but it would get a bad name depending on what reasons for back surgery are. If someone had just back pain, they just had wear and tear change in their spine, and you were going to do a spine fusion, well, I would say that statistic is not that good. It's marginal at best. And the chances of someone saying I did great after a spine fusion for my back pain is on the lower side. Probably highest statistics, maybe 60%, possibly up to 70%, but not a great odds. So if the reasons are good and they're fit, then it can be very satisfying. Now, the one other thing that can happen with this narrowing, the spinal stenosis, can be some instability. It's a little hard to see here, but you can see the bones lining up one on top of the other in these three, and the back wall of all those bones lining up. But right here, there's a little step off to continue down. That little slip is called spondylolisthesis. And you can just imagine how the spinal cord is having a more difficult time coming around this corner than it would be if it were straight. So when this does happen, we don't want to just open up the canal for the nerves, because this slipping invariably would be more unstable and the slip would get worse and then pinch the nerves all over again. So this would be a good indication to do a spine fusion. And you can't just put metal there. If you ever just put metal, it would be just like a tin can that you would have microscopic motion continuously there. Eventually it would break. So you've got to get a biological fusion, and that's what this bone graft is here on the sides. So in a situation like this, through the same midline incision, under the skin, go over to this pelvis bone. And you take a little cap off the top of this bone, and you scoop out as much bone from that ilium as you can. Then you put the cap back, and you sew it back, and you put the bone graft on the sides there. And that's something that the person that would have a surgery like this, again, the 80% good and excellent results for spinal stenosis, they would probably stay in the hospital 2 to 3 days. And they'd use a brace for about 12 weeks. And the other interesting thing with that, where smoking comes into play, when you put this bone graft in here, someone who is a non-smoker, the fusion rate is 92%, which is good. Just add smoking in there and it goes down to 66%. And that has been on studies that have been reproduced. And why is that? It's probably the microvasculature around the bone graft. So here's an intraoperative picture. This is from the side. This is what we see in the midline. This is the spine. You can see these spinous processes here. So this is the level that was narrowed, and so we take away anything that's pinching the spinal cord. So this is the actual spinal cord here, this tube. It's kind of a light blue, robin's egg blue or grayish material, and it's a covering of the nerves inside, and the nerves inside are bathed by a cerebral spinal fluid in there. And so this is a wide open canal, so now those nerves are not being pinched anymore. And we talked about fusion for back pain. It's not common. It's something that is a possibility. If someone had very severe back pain, it was clearly identified to be one level, maybe two levels. We could be certain we know what the pain generator is. It's a possibility. Here's a spine fusion. If we do it for back pain, oftentimes we'll put a wedge in the disc space to take out the entire disc, fill it with bone, so this would have a higher chance of fusing and being one solid bone. Total disc replacements. They're available, they're FDA approved. It's something that is a possibility for someone with a degenerative disc. However, it's not common that somebody would have one or two levels of degenerative disc, and that's clearly the cause of their pain. And it also has to be the case that the facet joints in the back don't have any significant arthritis. So you don't do much good for somebody if you do a disc replacement and then the arthritis continues to be significant trouble for them. So it's available, it's just not commonly an indication. So what should we do with back pain? We should be flexible, moving the joints, making sure the facet joints are mobile. I think we do get into trouble if we're too sedentary and the facet joints are stiffened. One symptom of arthritis we'll see someone gets up first thing in the morning, or if they've sat for dinner for an hour and then they go to get up, those joints then moving in arthritis can be painful. So the theory of keeping them mobile is good. Medications, mostly non-steroidal anti-inflammatories, Tylenol with caution. Injections can be done in the epidural space. They can be done in facet joints. Chiropractic or other manipulations, not greatly proven in the literature, but possible. Not proven, acupuncture, magnets, massage. But we all know people who have tried some of these things, sane people who we would trust, and they say that they found an improvement. Whether it's a placebo effect or whether it's real, hard to determine. So exercise. A study in the elderly proves 2 to 3 days of some exercise a week can make a difference. The other thing that I never think too little of are these endorphins and enkephalins, these things that our brain secretes. You've heard of the runner's high, and there's such a thing as a runner's high. These long-distance runners, they get out there every day, and they have to get out there because if they don't, they're depressed. And they've got to get out there. If they have a flu and they can't run for a week, they're a mess, because they do secrete these endorphins and enkephalins that are kind of natural highs. So when we have issues of back pain and other things, I look at some way, how can we get this natural high for someone? Whether it's walking or swimming or yoga or what it is, I think an exercise can make a difference. Core strengthening, all of these things have a role. The medicines we talked about, glucosamine chondroitin sulfate, it is a material you see advertised. It's in all the drugstores, osteobiflex, different names. It is a material that makes up cartilage, and so it was felt that, could it help cartilage in an arthritis situation? Not proven. Reason I still think it could have a role is that it's, number one, it's natural. Number two is there have been some studies where they've seen it tagged and absorbed in stomachs, and they go to joints. Limited role for narcotics. You certainly don't want to get on a routine use of a narcotic because they can be addicting and problematic. Spinal manipulation, safe, possible, not proven. Massage, same thing. And acupuncture, the same thing. Magnets, same thing, definitely not proven. No difference in low back pain from sham magnets. And the last slide, if you're in the back, this is somebody with multiple needles in them, and the caption at the bottom says, "You've got to be kidding, your back still hurts?"
Find out more at smao.org.